Start the session on pediatric ophthalmology free paper. We have with us Dr. K.K. Mehta sir and Dr. Shreya Shah. I am Dr. Rishikesh. So let us start without any further ado. I invite Dr. Ashok Sharma. He has to go for another session, so we request him to share his paper on pediatric corneal transplants, a review of 21 years.
Okay. I will be presenting on pediatric corneal transplant, my experience. It's still not moving. I have no financial interest in this presentation or in instruments used in this study. Ever since the first corneal transplant was performed, there have been significant improvement in eye banking, in surgical techniques, and also the new surgical procedures like endothelial keratoplasty have been introduced. But still, penetrating keratoplasty remains to be the gold standard for most of the diseases in adults. And the results have been gratifying. In some of the studies, even 10 years success for penetrating keratoplasty has been reported for more than 90%. But the scenario for the pediatric corneal transplant is different because of the challenges which we face because of the small eye in the children and shallow AC, forward bulging, and high risk of iris prolapse and other complications during surgery, plus increased risk of graft rejection, and of course, visual rehabilitation and child cooperation is very poor. And also the long-term outcome of pediatric corneal transplants are not very much that much described in the literature. So I will be describing our experience. This is a retrospective study, non-comparative intervention. This was approved by the local institutional review board. We have retrospectively taken out 213 eyes of 178 children who underwent penetrating keratoplasty, for 178 for penetrating keratoplasty and 35 for deep anterior lamellar keratoplasty. Those patients who had more than 6 months follow-up, they were included. For surgical steps, the surgery was under general anesthesia, and the donor trepanation and host trepanation was decided on the basis of child's corneal diameter, and most of the times if the diameter was 8 or 8.56 millimeter graft was given. Higher endothelial cell count donor corneas were used for these children. We used all the intraoperative measures to decrease the intraoperative positive pressure, and we monitor the body temperature by keeping the temperature of the operating room for neonates. And in post-operative treatment, we did frequent topical steroids and also frequent EUA. These are some of the indications and congenital and acquired for penetrating keratoplasty. For verbal cases, more than 50% of the children, they could achieve more than 660 vision. And for non-verbal children, they were able to do their activities. And some of the children, they did not improve because of undetected optic nerve problems. There were several success stories, but just to share this one, this patient came to us with bilateral sclerocornea, bilateral microcornea, microphthalmia, and she was 5.5 months old. We did one eye in 2017, and she improved. The other eye was done in 2018. Now she is 6 years old and is going to school. She had one episode of graft rejection which was successfully treated. This is another group of the patients which is technically more demanding because these patients having infantile glaucoma, their cell loss is much more compared to the normal patients, and more so if we have to do the tube for these patients. Deep anterior lamellar keratoplasty is much safer for the children, so these are some of the indications, and the complications are also less, and we have better results for deep anterior lamellar keratoplasty. Wherever possible, we do deep anterior lamellar keratoplasty for children, and our results are almost similar to those reported in the literature. In the end, I would like to say that the PKP remains the gold standard for visual rehabilitation in most of the children and infants. And it's only that if you have a congenital hereditary endothelial dystrophy or a failed graft, you can go for endothelial keratoplasty. Pediatric keratoplasty is challenging, but it gives good results, and good survival can be achieved with monitored follow-up. DALK is safer and less invasive and has better graft survival than compared to the complications. Some of the centers, they advocate Boston K-Pro for children as a primary procedure. We do not believe that, and we do not advise that. Endothelial keratoplasty can be done for selective cases. Thank you very much for patient hearing. Thank you.
Thank you, sir. I want to, just a question. What percentage of pediatric keratoplasties you are doing penetrating keratoplasty versus the lamellar procedures?
The incidence of deep antilamellar keratoplasty is much less. Maybe like if we are doing 8 or 10, then we are doing 1 lamellar.
Keratoconus. How many had a keratoconus, and you preferred DALK only in keratoconus, or you did PKB?
Well, the problem with DALK in children is that sometimes they come in a very, very advanced stage and acute hydros, where the deep antilamellar keratoplasty is not possible. Another group of patients which I have done, they have Down syndrome along with the keratoconus. So they are also very advanced. So I do DALK for children, but most of these children, they are not fit for DALK. And also those patients who have like vernal conjunctivitis with keratoconus, there of course we should not do penetrating keratoplasty. There we should do DALK because of the more risk of graft rejection, complications, and those problems.
Thank you.
Thanks.
Thank you, sir. I invite Dr. Professor Arvind Kumar Moria. Dr. Arvind Moria. I think he's not here. We'll go to the third presentation, that is by Dr. Mihir Kothari, sir. It is on accommodation scale, a ruler gauge for objective assessment of magnitude of accommodation in kids.
The first one, first folder. Hi, you can do that. So good morning, my colleagues. Here I am quite excited to present a new scale which you will be able to use for objective assessment of accommodation in your pediatric patients. I have no financial disclosures to be made. Accommodation abnormalities, many of you are aware, is not uncommon in children. As many as 80% children with Down syndrome, 50% children with cerebral visual impairment, and a significant number of children with foveal hypoplasia, ectopia lentis, suffer from accommodative abnormalities. Accommodative abnormalities are also seen in patients who have unilateral or bilateral amblyopia, various strabismic disorders, patients complaining of asthenopia, and patients started on various concentrations of low-dose atropine. Current clinical methods like dynamic aberrometry and open field autorefractometry are less accessible, quite expensive, and marred with underestimation of accommodation, and hence most of us, the clinical pediatric ophthalmologists, would like to rely on dynamic retinoscopy. In our 2019 survey of the group of pediatric eye surgeons of Mumbai, less than 5% pediatric eye surgeons were confident enough to be able to use dynamic retinoscopy when it was required. We described this technique in which photorefraction was used when the child was looking at a longer distance, and then the distance was reduced, and the accommodative reflex in the transpupillary area changed from superior crescent to an increasing inferior crescent as the distance was reduced. As visible in this particular video, when the child is looking at distance, the crescent is up, and as the child starts looking at near, there is a prompt reversal of the crescent inferiorly, which keeps increasing as the distance keeps decreasing and the accommodation keeps increasing. These were validated in two studies, 2012 and 2019, in which we found the technique of dynamic distance direct ophthalmoscopy as well as estimation dynamic distance direct ophthalmoscopy was having near 100% correlation with current gold standard of dynamic retinoscopy, albeit it had better sensitivity. When combined with a neutralization technique like what we do for minimum estimation method of dynamic retinoscopy, you can neutralize this inferior crescent and find out the exact amount or the magnitude of accommodation that the child is exerting when looking at a fixed near distance. However, this technique was also not picked up by our colleagues in Mumbai, and hence we decided that let's get away completely with the neutralization insertion or interjection of the lens and create an accommodation scale which can be used and compared it with the dynamic retinoscopy and validated again on the same group of pediatric eye surgeons. The way the scale was derived was we asked the child to look at a distance. This child was emmetropic, And while looking at a distance, we introduced or interjected the positive lens in the step of 0.5 diopter from 0 to 5 and derived this kind of a scale where there are 11 serial photographs showing an increasing amount of crescent. This scale was quite similar to the previously used scale in ophthalmology, like the Kestenbaum scale for pupillometry or the ulcer scale or the JLC grading card used for cup-disc ratio, AV ratio, etc. We compared this scale in normal subjects with dynamic retinoscopy, and we needed 15 eyes for 90% power of the study at 5% significance level. A pediatric oriented optometrist doing her M-Optom included 5 to 16 years aged children with normal systemic health visiting a pediatric eye clinic for routine refractive checkup and were cooperative for both the tests. We had 17 children, of which 10 were males, and we performed these tests at 100, 50, 33 and 25 centimeter. As you see over here, there was a very good correlation between the two techniques. However, accommodation scale had less intra-test variability, while dynamic retinoscopy had a higher standard deviation and picked up lead of accommodation, which is quite common with interjection techniques. Then we validated the same scale among our pediatric eye surgeon colleagues on 10 different slides, as you see over here. With a 5.8 years experience, we found they were able to assess the magnitude within 0.25 diopter, and 95% were confident of using it. The only problem or the limitation is it is still an interjection technique. It is best to use an Android or iOS app which can take the photograph and automatically tell us about what is the actual accommodation. So it is quite easy and useful tool for assessment of accommodation in regular clinic. You may use an accommodation scale. Download it from drmirkothari.com. Thank you very much.
Thank you, sir. Thank you for a very novel approach for dynamic retinoscopy. Just out of curiosity, I would like to know, how did you video record the reflex when you actually showed it?
Just like you put your eye behind the ophthalmoscope, you put your iPhone or an Android phone behind the ophthalmoscope.
Okay.
You can use an app also. It is called DM Eye Care app, which was invented in US, basically to pick up the retinoblastoma using the transpupillary reflex. If you take this MD Eye Care app, you can also derive these photographs. It requires darkness and calibration in the dark room. Focus when the light is on, then switch off the light, then take the photograph, then you can pick it up. MD Eye Care is the app. Thank you.
Thank you. We go to the next presentation. Low-dose ranibizumab in the treatment of aggressive retinopathy of prematurity by Dr. Shreyanshi Biswas.
Please make it on. Please make it run. Oh, that's nice. It's not coming. It's not running there. Another page of someone else is there. Good morning, my respected delegates and my friends. Today I'm going to present before you the low-dose ranibizumab in the treatment of aggressive retinopathy of prematurity in India. So we all know what is AROP. It is the most aggressive form of ROP as it directly progresses to retinal detachment without going to the normal stages of ROP, and its meticulous management right from the beginning is very important hence. there has been gradual evolution in the treatment approach of AROP. Previously, it was ETROP had set forth of laser and cryotherapy as the mainstay of the treatment. But in those cases, in AROP cases, large areas of laser and cryo need to be happen, and that caused high myopia, high astigmatism, and hence strabismus and amblyopia. Next, the anti-VEGFs gave a new breakthrough, and the first anti-VEGF that came was bevacizumab, but then bevacizumab had risk of systemic side effects due to systemic penetration of the drug, and hence its use was hindered. Next, the ranibizumab gave again another breakthrough, but though its systemic side effect was almost nil because of nil systemic absorption, but since due to its shorter half-life, there was again a recurrence rate is high. And requirement of secondary laser photocoagulation is also required in a large number of babies, because a large number of babies is seen to have avascularity right from zone 2. The requirement of secondary photocoagulation after ranibizumab is almost 80%. Recently, CARE-ROP study done in Germany has given a new breakthrough, because that has gone through the application of low-dose ranibizumab in the treatment of ROP, and it has shown promising results because of good vascularization potential as well as good effectiveness in controlling the acute disease. So here is my rationality of the study and as well as my objective, where I have tried to show, I have shown the comparison has been done between the normal dose and the low dose in terms of recurrence and vascularization status. So my study was an interventional trial, academic interventional trial. No financial interest was there, and all ethical committee clearance was taken. And I have taken my sample size as 34, and I have taken AROP babies, and both zone 1 AROP and zone 2 posterior AROP has been selected. And purposefully, what I have done is that in both the groups, I have equally divided the zone 1 AROP cases and zone 2 posterior AROP cases, maintaining all my inclusion and exclusion criteria. So these are my results and analysis. My results and analysis are in terms of recurrence, complete vascularization status, as well as incomplete vascularization with or without ROP. So coming to my recurrence status, what I have seen is that in recurrence with low dose, in recurrence with normal dose, here I have seen, yeah. Here in recurrence with normal dose, there is odds risk estimate of 2.13 more recurrence than that of the low dose in cases of zone 1 ROP. In the zone 2 posterior ROP cases, what we have seen is that with the, because it contains zero value, so odds ratio calculation was not possible. We have calculated the confidence interval, and that found to be significant, in signifying that normal dose zone 2 in zone 2 posterior ROP is seen to have more recurrence values than the low dose. So here is a picture of recurrence of AROP. The complete vascularization analysis, when it was done, it was seen that in both the groups, both zone 1 and zone 2 posterior AROPs, in both of them, the low dose had significant good vascularization status than those of the normal dose. And here you can see that zone 1 AROP has good, very good vascularized up till zone 3, up till aura. And next, coming to the incomplete vascularization status, what we have seen is that in this case, the zone 1 AROP cases with normal dose has seen to have more persistent avascularity than that of the low dose, and that is a 2.3 times higher odds risk ratio. But that is not in the cases of the zone 2 posterior ARP. That has not shown any significance. So, in discussion at last, I want to show you some important facts that with low dose, we have got in zone 2 posterior ARP complete vascularization. But in the cases of zone 1 ARP, what we have found is that eyes which are remaining persistently avascular, only the zone 3 area is remaining persistent as avascular, not any other areas. So ultimately I'm requiring very much.
Please conclude the times.
Ultimately I'm requiring very much lesser area to laser. But it is not in the cases of the normal dose, because the eyes which are remaining persistent avascular, they are having both those avasculating in zone 2 and zone 3. So still normal dose is requiring a large area to be lasered. So here you can see I have lasered one to low dose and only the zone 3 has been lasered. So it is a very small area. So my conclusion is that yes, low dose ranibizumab is really found promising with good vascularization status in AROP cases, and in the long run requirement of laser with unforeseen consequences both in terms of systemic and visual risk can be lessened. And of course, last but not the least, it is very cost effective also. So my limitation is only small sample size and single center evaluation. Thank you.
Thank you.
Since the ranibizumab
Yes, ma'am. Maximum, I have given two injections.
2 for each, for zone 2, zone 1, everybody?
No, zone 1. Ma'am, actually what happened, if you have seen that it has approached zone 2 and more, then we have not applied second time injection. We have done the laser. But if a recurrence happened in zone 1 only, then we had to give another time injection just to avoid large areas of laser application.
So how many in your study you had to go for laser also?
How many I have to do the laser? Ma'am, it is in the normal doses, it was as much as 80%, ma'am, because not in the low doses. Low doses is hardly 40%, when as a whole, considering both zone 1 and zone 2 posture did not require any laser, only the zone 1 cases of the 40% only. Thank you, ma'am.
Thank you. Thank you. We now invite Professor Arvind Kumar Moria. His presentation is a clinical trial on phakic IOL versus Oclutab versus Orthoptec in children for management of amblyopia.
Can somebody help?
Display. No, Mumbai. It's an honor for us to be with. Next. Dr. Nikhil Balakrishnan is there? Okay. After this.
Both? Yeah.
Good morning, respected judges and my dear friends. So my talk is on the world's first such clinical trial on phakic IOL versus Oclutab versus Orthoptec in children and adolescents for the management of amblyopia. So amblyopia is a neurodevelopment ocular disease manifested as monocular and binocular impairments, including vision reduction, contrast sensitivity, or even loss of stereoscopic vision. So occlusion therapy with best corrected spectacles, they have recurrence rate of 25 to 50%, and there is this Oclutab is also there. So there is binocular polarized glasses are used. Same background is given, but the enriched foreground to the amblyopic eye is given. So the high contrast to the amblyopic eye and fast-paced engaging components are there. So it is based on the principle that they can strengthen a broad range of visual tasks in adults with normal vision, including light sensitivity, contrast, visual crowding, and visual attention. So this is how it is done. And now there's new treatment modality, that is orthoptic magnocellular stimulator. So there are 3 rows of LED lights, and the central one is green and the rest are red. And the light comes on and off for 150 to 200 milliseconds, and the patient fixates at the light and points at the flashing lights with a laser pointer. And the patient seated at 1 meter distance with best corrected visual acuity glasses. So 20 minutes with the amblyopic eye and 5 minutes each for the better eye, and 5 minutes with both the eyes. So this is how the saccadic area and the attention area, so they works opposite to each other. But the 4C alpha in the saccadic area, it stimulates the 4C beta, the parvocellular cell in the retina. So this was the world's first such clinical trial to analyze the demographics and clinical outcomes of phakic IOL versus Occlutep versus Orthoptec in the management of refractive amblyopia. So this was our methodology. It was a prospective interventional study on children and adolescents with amblyopia at a tertiary eye care center from Jan 21 to Jan 23, and 63 eyes of 63 anisomyopic and 3 isomyopic amblyopia patients were randomized in 3 groups: phakic IOL, group A, group B Occlutep, and group C Orthoptec. So the patients were followed up at day 1, 6 weeks, 3 months, and 24 months after treatment. So these were the results. Demography, so almost male to female ratio was equal in all the 3 groups. Now coming to the visual acuity. So as we compared in the phakic IOL group, so there was a significant p-value from 1.39 log mark. The visual acuity improved to 0.11. And again in the group B, there was a significant p-value as compared to the visual acuity improvement from 1.35 log mark to 0.12. And also it improved in the group C also, 1.37 log mark to 0.12 in the Orthoptec group. Now coming to the contrast sensitivity between pre-treatment to the post-treatment in the 3 groups. So the improvement was best in Orthoptec group with a significant p-value as compared to the Occlutep as well as the phakic group. And as we compared the comparison of stereoscopy between the pre-treatment to the post-treatment, so it takes longer time in the phakic IOL group as compared to the Occlutep and the Orthoptec group. So there was faster improvement in stereoacuity in the Occlutep and Orthoptec group. So in the conclusion, in amblyopia there is a functional or structural deficit in the visual cortex, and the functional bold MRI, the blood oxygen level dependent MRI scans do shows us the way forward. As you can see the upper picture, it's a normal patient. The second patient is amblyopic with reduced oxygen level, and after Orthoptec treatment and after Occlutep, there was improvement in the blood saturation level. So repeated stimulation of the magnocellular cells, they leads to stimulation of fovea, and these prosaccade is associated with maximal stimulation of the V1 area in the visual cortex. So the Orthoptec magnocellular stimulator is a novel instrument in the management of anisomyopic and isomyopic amblyopia in terms of faster improvement in contrast sensitivity, stereoacuity, and multicentric clinical trials are of course needed in other amblyopia and other attention deficit disorders. So future is absolutely combination of different methods of management of amblyopia. Thank you so very much.
Thank you, sir. Thank you for the novel approach towards amblyopia. So amblyopia actually is not a uniocular phenomenon where we need to patch the eye. Nowadays, a lot of new treatments like Orthoptec and dichoptic exercises have coming. What is your, when you compare the phakic IOL, the outcome in unilateral myope versus the Orthoptec exercises?
So in the densest of these isomyopic and the anisomyopic, we use phakic IOLs. So visual acuity improvement was faster in the phakic IOL group. But it took stereoacuity and the contrast sensitivity, it took a longer time in the phakic IOL group. So now what we are planning in a newer study that we need to combine these studies. So after putting phakic IOL, so no glasses is required now, or minimum, very minimum glasses are required. And then we can opt for Occlutep and the Orthoptec. Those patients are improving very fast.
For this Orthoptec, how frequently you advise the sessions, because it doesn't work every time within one session. It doesn't improve. So how frequently you advise?
So we are doing weekly, alternate day for 20 minutes with the amblyopic eye. And the problem is in the Orthoptec magnocellular stimulator, when we first started, so results were not good. So then we get to know that we need to sit along with the patient, we need to sit along with the child, we need to keep them motivated. So we need to keep them occupied. So they were not doing it. But once one of our staff was sitting with them, so the results were really good.
Yeah, I agree. The result, and we are also using the results are good. Any experience for strabismus improvement pre and post ortho?
Yeah, we are also doing it in strabismic amblyopia. The degree of the strabismus is also decreasing. I don't know why. In few of the strabismic amblyopia, the degree of the strabismus has decreased. I don't know why.
Because in our study, we could not find any difference in strabismus, but we definitely found the difference in contrast sensitivity.
Nystagmus also improved.
And nystagmus, contrast sensitivity, and
Yeah.
stereoacuity.
Thank you so very much.
I invite Dr. Nikhil Balakrishnan for his presentation. He will be presenting effect of amblyopia on macular thickness, microvasculature, and RNFL thickness in children.
Good morning, everyone. My topic for today is effect of amblyopia treatment on macular thickness, microvasculature, and retinal nerve fiber layer thickness in children with unilateral anisometropic amblyopia. Now, we all know amblyopia is the reduction of the BCVA of one or both eyes that cannot be attributed to any structural abnormality of the eye. And anisometropic amblyopia is a difference in the BCVA of the two or more lines of acuity between the two eyes. Amblyopia is very rampant, the prevalence of which is as high as 1 to 5% in the world today. And it is the characteristics of it is poor visual acuity, reduced contrast sensitivity, and poor binocular vision. Now, we all know that the management of amblyopia is either with occlusion therapy, penalization, or digital dichoptic therapy, which is being used widely nowadays. Published literature already shows us that digital dichoptic therapy is very good in the treatment of amblyopia. But our research question for our study was, is there any anatomical changes in the eye which correlate with the effectiveness of the digital dichoptic therapy for amblyopia treatment? It was a retrospective study with 90 eyes of unilateral anisometropic amblyopia included in the test group, and their contralateral eyes were included in the control group. Patients were between 6 to 14 years. Unilateral anisometropic amblyopia patients were only taken, and the exclusion criteria have been mentioned here. Once the patient was diagnosed with unilateral anisometropic amblyopia, all patients were made to undergo an OCT for macular thickness, RNFL, and an OCT angio 2. They were then given digital dichoptic therapy. We used the Binoc software for 30 minutes daily, 5 times a week for 6 weeks overall. Following this, we did a reassessment of all the parameters to see if there were any improvement. And we also did a reassessment on the OCT and the OCT angio. As a part of the study, we did a manifest and a cycloplegic refraction, a BCVA, stereo acuity was checked by the Randort's test, Wirth's 4-dot test to check fusion, and a slit lamp and a detailed fundus examination. Now, on the OCT, we are checking the macular thickness, the retinal nerve fiber layer thickness, and on the OCT angio, we are checking the superficial and the deep capillary plexus vessel density. Now, we all know Binocs, we use red-green glasses for dissociation, and we do dichoptic and fusional vergence exercises during the same. So what were the results of the study? There was no gender bias in the group. Improvement of BCVA, almost 93% of the patients showed an improvement in the best corrected visual acuity, and only six patients out of the 92, that is 6.67%, showed no improvement, which is statistically significant. Improvement in stereopsis. At the start of the study, 74 out of the 92 patients had no stereopsis, whereas at the end of the study, only 13 patients had no stereopsis. So 82% got an improvement of stereopsis with the therapy. Similarly, in cases of fusion, 79 patients out of the 92 did not have fusion before the therapy, and only 11 of them did not have fusion post-therapy. So an 86% improvement was seen, which was statistically significant again. Now, this is where things get interesting. Coming to the macular thickness, we noted that the macular thickness of the amblyopic eye was much higher as compared to the control group. And after giving them 6 weeks of therapy, the macular thickness came down significantly and became almost equivalent as much as the control group, again showing statistical significance. Similar findings were seen in retinal nerve fiber layer thickness, where the thickness was much more in amblyopic eyes and reduced drastically after therapy and came equivalent to the control eye. Now coming to the retinal nerve fiber layer density, if we see here, the amblyopic eye had lesser superficial and deep capillary plexus density as compared to the control eye, but after successful 6 weeks of therapy, this almost came back to near normal in cases of superficial and almost came back to near normal in cases of deep capillary plexus. Now, the interesting fact, the 6 children who did not improve post-Binox therapy after, out of the 92 showed no decrease in the macular thickness, no decrease in the retinal nerve fiber layer thickness, and no increase in the superficial and deep capillary plexus densities. Hence, we conclude that use of digital dichoptic therapy helps in improvement of BCVA, stereopsis, fusion, decreases the macular and the retinal nerve fiber layer thickness, as increases the superficial and deep capillary plexus density. So our study demonstrates that anatomical changes in the retina following amblyopia treatment, it's the first to use OCT angio for the same, and demonstrates the correlation of digital dichoptic therapy with anatomical changes. How do we translate this to the clinics? If we see no anatomical changes in the retina following digital dichoptic therapy in patients whose vision didn't improve, and we routinely perform an OCT and an OCT angio 6 weeks post that, we can stop digital dichoptic therapy, as we know that these patients are not going to improve further. The limitations of the study is we can also study other types of amblyopia, and if we can use human cadaveric studies to corroborate the anatomical changes in the retina and the lateral geniculate body. Thank you.
Thank you, Dr. Nikhil. Just a question. I mean, does OCT have a prognostic value? I mean, in terms of if you know the macular thickness before we start dichoptic or any amblyopia treatment,
yes, sir,
can we actually predict how much will be the visual?
Yes, sir. So the study says exactly the same thing, that we did OCT pre and post-op. We see that patients whose macular thickness and the retinal nerve fiber layer thickness is decreasing after 6 weeks are the only ones who are going to improve with giving digital dichoptic therapy. After 6 weeks, if we see that there is no improvement, that means there is no decrease in the retinal nerve fiber layer thickness and the macular thickness, these children, irrespective of how much further you continue giving them digital dichoptic therapy or patching or penalization, are not going to improve further. But these are the patients who are not going to improve. So that's the whole idea of the study, that after 6 weeks, if you're seeing no improvement, there is no point further burdening the patient and continuing giving them Binox or any kind of other therapy, just giving and trying to expect any results. So it gives us a definitive answer that, you know, if they are not improving, then we don't need to continue it. And was it the same after 1 year or 2 years? So our study period was only 6 weeks. 6 weeks we did the study, and then we went up to 3 months maximum. We did not go up to 1 year itself, because all published literature shows that within 6 weeks of therapy there is improvement with Binox. Multiple papers have already been published. That is why we kept our study period limited to that itself. So usually usually patients, what happened is after giving the therapy, they usually maintain with it. They usually do not deteriorate. We have continued the study further. We're almost 1.5 years into it. It's not included in this part, but we have seen that patients are remaining sustained with that itself. There's no dip in the thing for the... No, it remains same as the control therapy. We did all the tests at one. None of them increased again. So it remained reduced almost as similar as the control eye, which was the normal eye, which was seeing well.
So there is no relapse of the...
There's no relapse of this.
Okay. Thank you, Dr. Nikhil.
Thank you, sir.
We invite Dr. Debolina Deb. She'll be presenting her paper on association of endothelial in NOS polymorphism in babies with ROP.
Good morning, respected judges and everyone. My name is Dr. Debolina. I'll be presenting on the association of ENOS polymorphism in babies developing ROP. My co-guides are Dr. Suhasa and Dr. Mutaya, sir. I have no financial conflicts of interest. So coming to the introduction, we know that preterm babies, specifically with a gestational age of less than 34 weeks and birth weight less than 2 kg, they are prone to develop ROP, specifically if they have had a prolonged mechanical ventilation associated with sepsis, anemia, bronchopulmonary dysplasia, intraventricular hemorrhage, and multiple transfusions. They have a susceptibility of developing ROP. But under the similar conditions, we see some babies who do not develop ROP also. That leads to a question, perhaps there's a role of some genetic predisposition or not. So I'm specifically talking about the eNOS gene, which is seen in the short arm of the chromosome 7. And I'm going to talk about the two SNPs, that is the 786C and the 894, which is seen in the promoter region and exon gene of the 7q. And it helps in translating the eNOS protein, that is, converts the L-arginine to citrulline, and it also releases the nitric oxide. Now, why am I so much interested in the nitric oxide is because it plays a great role in the vascular smooth muscles and leads to the vasodilatation, and it perhaps plays a role during the angiogenesis process of ROP and the vascular development. So coming to the aim of my study is to study the polymorphism in the eNOS 786 and the 894 gene in preterm babies who develop ROP and those who do not develop, and compare the two. Ours was a prospective observational study done in a tertiary care center in South India over a duration of 1 year. We included 103 preterm babies with gestational age less than 34 weeks and birth weight less than 1750 grams. For them, we collected the buccal swabs to extract the DNA, following which we ran them for the PCR, and after getting the PCR products, they underwent microplate restriction fragment length polymorphism. For eNOS 786, we used the MS1 enzyme, and eNOS 894, we used the BAN2 enzyme. So this was the scoring for the eNOS 786, which had the base pair length of around 180 base pair, and accordingly they were analyzed as TT, that is a wild type, TC being the heterozygous type, and the mutant type was the CC. And for the 894, the base pair size was 258. Again, they were divided into the GG, the wild type, heterozygous GT, and the mutant TT type. Coming to the results, out of the 103 preterm babies, 24% developed ROP, out of which 9% required some kind of treatment, mostly with laser photocoagulation. Coming to the demographic risk factors associated, we saw the babies with with ROP had a lower gestational age, that is 28 weeks, as opposed to the 31 weeks in the ones with no ROP. The ones with ROP again had a lower birth weight. They had a prolonged mechanical ventilation, and also history of blood transfusion was greater in the babies developing ROP, and these were statistically significant. Now coming to the SNP analysis, so what we saw that when we studied the eNOS T786 gene, we saw that a greater number of babies with ROP had a greater number of C allele, that was the mutant type, and these babies had a 3.16 times greater risk factor, odds risk ratio of developing ROP with a p-value significant of 0.002. Whereas, coming to the analysis for the eNOS G894 gene, we saw that the babies with, the mutant T allele type had 3 times greater odds risk of developing ROP, and that also had a risk, the p-value of 0.02. So coming to the discussion, we know that ROP is a passive proliferative disorder seen in preterm babies, and they have a multifactorial risk factors associated for developing it. But there's also some genetic predisposition postulated, and till date we have seen a lot of studies done on VEGF, IGF-1, BDNF, and ACE. But I'm specifically going to be talking about the eNOS gene. Coming to the studies that have been done till now, there have been studied by Yu et al. They've seen the analysis of the NOS3 polymorphism and oxygen therapy, and they have found a protective role in the eNOS 786, that is the C allele, in the babies developing ROP. Whereas the study by Yanamandra et al., they saw both the 786C and the 894T. These are the mutant types that were there, seen to be associated with ROP in both the Caucasian and the African American babies. And the study by Michalek et al., they also found that the TT genotype and the T allele, that is the mutant type, were associated with eNOS. I'll just wrap it up quickly. So there were other studies where they did not find any difference in the genotype allele distribution between the ROP and the no ROP group, and there was a meta-analysis also where they saw that there was not much difference between the 786 particular polymorphism and ROP. But there was the study by Ilga et al. Where they found a positive correlation between the eNOS, that is the 894, SNP, and ROP, which is similar to our study.
Please conclude.
I'll wrap it up. So to conclude, basically there's no study done on any Indian population describing the eNOS polymorphisms. So we found that amongst the subset of South Indian preterm babies, the ENOS 786C, that is the mutant type, and the T894, again the mutant type, has a greater risk, around 3 times higher odds ratio of developing ROP. Thank you.
Thank you. Thank you. Any questions?
We invite Dr. Aditya Shetty.
Aditya is coming.
He's coming later. Okay, sir wants to go.
We now invite Dr. Faisal TT. He'll be presenting on visual field indices in glaucomatous children and adults with comparable RNFL thickness.
Very good morning, the delegates and the respected judges, and thanks for AIOS for presenting our work. That it is visual field indices in children with glaucoma compared to that in an adult glaucoma patient with comparable RNFL thickness. I have no financial interest to disclose. So we know that in clinical practice, the visual abnormalities in children with glaucoma are compared with adult normative data because there is a lack of normative data for the children. So the optic study showed that the children do not attain the adult visual field sensitivity till at least 12 years of age. And an abnormal visual field measured in the child may be normal for that age group since the sensitivity compared with the adult normative value. With this background, we studied, our aim was to determine the visual field defect and visual field defect detected on the Humphrey visual field in child with glaucoma and compare with the adult glaucoma with same RNFL similar RNFL thickness. So the informed consent was taken from the parents and the study was cleared from the Institute of Ethics. And this is a prospective observational cross-sectional study, and the children between 6 to 18 years were aged with glaucoma as per CGN criteria were included, and the inclusion criteria was children with glaucoma more than 20/40 vision acuity and the clear media, ocular media, and the exclusion criteria was any attention deficit syndrome or any disease which known to affect the visual field of the child. So all patients underwent visual field testing on Humphrey and the RNFL thickness was measured on the OCT. Adult glaucoma patient who had previously undergone visual field testing and were retrieved from the database. And for every child enrolled, a glaucoma patient with same RNFL thickness were identified, and the only reliable visual field were included for the analysis. The mean outcome measure was mean deviation, pattern standard deviation, and for the child, and the children between children were classified as children less than 6 to 11 years, and children was 12 to 18 years were analyzed separately. The minimum sample size required were 17 patients per group, and relevant stats were used. We have 46 eyes of 37 children with glaucoma compared with RNFL matched adult. The mean age was, the diagnosis were predominantly PCG in smaller children, whereas the juvenile open angle glaucoma in elderly children. And the logMAR vision acuity and the IOP were comparable in both groups. The average RNFL thickness was 72 micron and 68 micron respectively, and they were comparable. Now note that the mean deviation of the younger children was much better as compared to the older children, and also the PSD values of the older children are much higher as compared to the elderly children. Now when we compare the similar same patient with comparable RNFL thickness, we could find that though the mean average thickness was similar in all the groups, we could find that the mean deviation of the children was much higher. That means the children have much worse functional analysis as compared to the adult counterpart. And also we have the children have much higher PSD as compared to the adult patient with similar kind of RNFL thickness. Of course, the adult performed the visual field faster as compared to the children as we expected. Here I have a 10-year-old boy with PCG and 15-year-old patient with steroid-induced glaucoma, and an adult 65-year-old adult with a similar RNFL thickness. Now he could notice that even though our mean average thickness was similar, the children have worse mean deviation, as could see the mean deviation plot of the children. So to conclude that, the children between 6 to 18 years appears to have worse mean deviation and PSD as compared to adult. And the children may be wrongly labeled as more severe glaucoma due to lesser MD when associated in comparison with, when assessed in comparison with adult glaucoma database. So we recommend to consider developing a separate pediatric normative database for the visual field assessment of children less than 18 years of age. Thank you for your kind listening.
Thank you for excellent presentation. Is it possible that the visual field in children were not very reliable compared to adults?
We took only reliable visual field for all the children. We will repeat it multiple times till getting a reliable visual field as a definite for the definite criteria for the study. Okay. All the patients were reliable. Especially, of course, the children less than 11 years will be difficult to get, but we usually get, once we do that at least 2 to 3 times if we repeat, they will learn actually.
Okay. Thank you. We invite Dr. Prasad for his talk, Dr. Prasad Vaimbe, for his presentation on Binox. Can we think beyond patching?
Good morning, respected judges and audience. I'll be presenting the paper titled Binox, Can We Think Beyond Patching? The last year in SPOCI conference, I presented the data till 1 year. Now I'd be happy to share the 2-year data now. I know no financial disclosures for this. So, well, as you know, Binox is basically a cloud-based dioptic therapy software for binocular vision assessment as well as therapy, and it employs simultaneous and separate stimulation of both eyes using anaglyphs. It has both diagnostic as well as therapeutic models, of which I have used the therapeutic model for amblyopia, which involves the computer-based games designed on dioptic stimuli. So the purpose of the study was to evaluate the effect of this cloud-based dioptic therapy software called Binox on visual acuity and stereopsis of patching resistant and patching non-compliant amblyopes, which were aged between 4 to 17 years. So it was a non-randomized interventional prospective study. 185 children with either anisometropic or ametropic amblyopia were included. The age group was between 4 to 17 years with a mean of 8.4 years and the sex predilection as shown in the slide. The inclusion criteria, they all were cases of either anisometropic or ametropic amblyopia with associated refractive error. They had stable vision and there was no improvement with patching on 2 consecutive visits. That means they were either patching resistant or they were self-reported patching non-compliant, and all were willing to participate in the study. The amblyopes, the strabismic amblyopes or associated ocular or retinal pathology or history of any ocular surgery, all were excluded from the study. Pre-Binox evaluation was done, basically a cycloplegic refraction with a best corrected visual acuity using Logmar as well as Snellen's equivalent. BAC was calculated using TNO, and the patching was discontinued if at all they were doing it. And the post-Binox evaluation, the same parameters were used. The follow-up was done at 1, 4, 12, 18, and 24 months post-treatment. Since it's a cloud-based software, that's why you have to have a good internet connectivity with minimum 512 kbps speed. You can have any desktop or laptop with a minimum 11-inch screen with a Google Chrome browser installed in it, and either Google Meet or Microsoft Teams or Zoom installed in it. How was the therapy session? The therapist and the patient, they connected remotely through the Google Meet or Zoom or Teams. Patient used either red, blue or red cyan anaglyph goggles. One-time calibration of computer for the size and the color as well as for the anaglyph was done. And the 30 sessions of dioptic therapy were given online for 30 minutes per day. Observations, these are the various patient data records. There was an improvement in vision and stereopsis. So of the 185 patients, 105 were male and 80 were female with a mean age of 8.4 years. Pre-therapy, only 22.5% had best corrected visual acuity of 6, 9, and 6, which improved to 35% post-treatment. Post-therapy improvement in distance as well as near vision which was statistically significant using Wilcoxon sign rank test, and also the stereopsis improvement was also statistically significant by a McNemar test. So according to me, what were the advantages of this software? Because since it's a cloud-based program, so it can be used as an easy telehealth vision screening as well as therapy program. And importantly, it was useful for patching resistant as well as patching non-compliant patients. Because of its remote use, it was quite useful in COVID lockdown period. And even examiner can remotely monitor the progress of the child. Now, what are the limitations of study? Last year I presented 1 year. Even after 2 years, the results are still the same. It has not deteriorated. It has not, the amblyopia has not resurfaced. But what is going to happen after 2 years, after 5 years, after 10 years down the line, I don't know. So again, second limitation, it still requires a good internet connection and a desktop or laptop, which can be still a distant dream for remote villages. And efficacy as a primary treatment, we don't know. So to conclude, best corrected visual acuity as well as stereo acuity improved after Binox dioptic amblyopia training and remains stable in patching resistant as well as patching non-compliant subjects aged 4 to 17 years with anisometropic and ametropic amblyopia 2 years after cessation of treatment, and it requires long-term studies to prove its usefulness as a robust amblyopia treatment option. Thank you for kind attention.
Thank you, Dr. Prasad. So at the end of 1 year and now, I mean, at the end of...
Yeah, it's still statistically significant. Although some of the patients, the vision has dropped down, but it's not statistically significant. So the the statistically significant improvement is still there after 2 years. I have the data of almost more than 500 patients, of which 185 only I could include because of their longer follow-up.
So you are prescribing, I mean, suggesting Binox as the primary treatment, or
I don't know.
only for
I think it will require head-to-head trial.
Okay. So, I mean, what was your experience with in the refractory amblyopia? I mean, those who did not respond with patching?
The same patients I included.
Okay. Only those patients you have included.
Yeah.
All together.
Yeah. That will be very interesting to see then.
Oh, okay. Thank you, Dr. Prasad. So we invite Dr. Kuldeep Kumar Srivastav. So he'll be presenting outcome of late probing for congenital NLD obstruction.
Very good morning to all of you. I will be presenting our study on late probing for...
Sir, into the mic, please. You're not audible. No, it's on.
It's on.
I will be presenting my study on late probing for congenital nasolacrimal duct obstruction. I have no financial interest to disclose. Congenital nasolacrimal duct obstruction is a common abnormality affecting up to 20% of infant. It presents with watering and discharge starting few days after birth, and site of obstruction is inferior portion of the NLD. The management is, first is lacrimal sac massage, which is very successful, around 90% of cases. If it fails, then one can go for the NLD probing. It can be done at 1 year of age under GA, and cure rate is around 90%. Some people prefer to do at 6 to 7 months under topical anesthesia to avoid hospitalization. And it can be done at later stage with a variable success rate. If probing fails, then one can go for DCR. So the purpose of study was to evaluate the outcome of late probing for congenital NLD obstruction. It was a retrospective study between January 11 to December 22, and medical record of all the patients who has undergone probing during the study period were reviewed. Inclusion criteria were initial probing between 2 and 5 years. It was by single surgeon, single technique, and minimum follow-up for 1 month. The patient with history of acute dacrocystitis, punctal or canaliculi abnormality, history of probing in the past, or follow-up less than 1 month were excluded from the study. The technique was simple, uniform protocol under general anesthesia, and it was done through upper puncta. After punctum dilator, Bowman probe was used to open the block in lacrimal duct. And after probing, steroid antibiotic eye drops were prescribed for 3 times a day for 1 month. The total was 325 patients during the study period. Out of that, 185 were between 2 and 5 years, and with the inclusion-exclusion criteria, there were 96 eyes of 72% eligible for the study. 48 children were in a unilateral problem, 24 has bilateral, 54% male, 46 females. Mean age at the time of probing was 36 months, and mean follow-up was 22 months. The procedure was considered to be successful if epiphora and discharge was resolved within 1 month of the probing. In our study, the success rate was 84.4%, and 15%, that is 15.6, that is 15% which failed. Out of that, 6% were those who were the primary probing was successful, but still they failed. So these patients underwent repeat probing and intubation, and the 9 patients where the first probing itself there was obstruction at NLD level, so they were directly subjected to the DCR. The probing is a standard treatment for any congenital lateral lacrimal duct obstruction if the lacrimal sac massage fails. Cure rate in older children is controversial, and success rate decreases by increasing probably because of chronic infection and fibrosis. Self-selection of process where the simpler cases get cured and complicated cases remains uncured. Various authors have done the similar studies in older patients and reported the various success rate ranging from 42 to 72%. In our study, it was better, 84%. Therefore, we conclude that late probing between 2 and 5 years is effective with good success rate. Probing should be attempted in older children prior to going for complex procedure like intubation or DCR. Thank you very much.
Thank you, sir.
Thank you.
Have you tried with intubation also, and what is the success rate with intubation and without intubation, especially after 2 years of age?
Yeah, first time we are not doing, first time we are doing simply probing, and it is failing, then we are going for intubation.
So you're not using intubation as a primary even after 2 years?
No, we are not doing primary.
And success rate was good, success rate was good, you are saying that?
Yeah, that's right.
And how, at what earliest age have you performed DCR in this kind of patients?
5 years.
5 years.
5 years.
Okay, thank you.
Thank you, sir. So Dr. Shweta Chaurasia, she will be presenting on developing and implementing CVI assessment and rehabilitative toolkit.
Thank you, judges. Cerebral visual impairment manifesting as complex visual deficits poses unique challenge. Standard of care includes neurological intervention with limited emphasis on visual rehabilitation. Recognizing this gap, we introduced a toolkit to address the diverse manifestations of CVI. So the objective of the study was to describe the process of development and implementation of a toolkit for assessment and improvement of functional vision of children with cerebral visual impairment. Methodologies consisted of systematic and structured approach in 4 phases, including a prospective pilot RCT after CTI registration. Initial survey consisted of conducting research, comprehending problems, defining objectives. Phase 2 consisted of identification of the core component, exploring the domains of assessment, brainstorming the ideas for the toolkit and the rehabilitation strategies, prototyping and revision of the tool design. Phase 3 consisted of validation of the toolkit and pilot testing of the randomized control trial. Phase 4 consisted of user feedback and toolkit refinement. In the methodology, the RCT consisted of 2 groups. Group 1 consisted of children with CVI receiving visual therapy kit, and Group 2 consisted of children receiving standard of care, and the study period was 1 year. Children 6 months to 5 years diagnosed with CVI were included, and patients of debilitating disease and organic pathologies were excluded. With the 80% power study, 25 patients in each group were selected. After the screening and enrollment, the randomization sequence was generated by the computer-generated method. The clinician doing the allocation was blinded from the examination. The baseline evaluation included history, CVI questionnaire, neuro-ophthalmic profile, neurovisual behavior profile. Follow-up was done at the end of 1 year, and the patient underwent neurovisual behavior assessment or the functional scores. The final toolkit we named as the OptiSync Rehab Assess Toolkit. The toolkit was implemented and tested by the RCT, and the improvement in the functional vision or the NVB score in the intervention group was compared to the control. As the name suggests, that the toolkit had 2 components: the assessment scale, which was NVB scale, which was for the comprehensive assessment of various domains and profiling, and the rehabilitation tools, which address the specific neurovisual behavior and functional component, functional vision scoring needs. The NVB score had 4 domains: visual attention, visual motor, visual communication, and visual processing, and along with the 57 items. It comprised simple and complex visual tasks and skills based on characteristic feature profile, which was dorsal and ventral streak. The rehabilitation toolkit comprised basic visual stimulation program, complex visual motor skills, simple motor task, and visual perception skills. Rehabilitative stimulation program had light therapy for the visual stimulation. The light-based exercises had light chamber for the visual stimulation, visual motor skills, and visual perception, and digital visual stimulation program was for the visual stimulation and visual perception. The light chamber was focused on the stimulation for attention. It was integrated with tactile stimulation, and visual motor integration was done for the hand-eye coordination. The visual processing included tasks for the size discrimination, visual search task, task with the visual clutter, visual discrimination and peg puzzles, and visual recognition tasks. These are some of the videos of the home exercises done by the children with the toolkit. Non-light rehabilitative exercises were done with the color and with the movement. The implementation was done with studying the change in the NBV score between two assessments in the RCT. Wilcoxon sign test was used to see the change between groups, and Mann-Whitney test was to see the change between the two groups. In clinical profile, birth asphyxia was the primary etiology. We did the neuroophthalmic, oculomotor, and CVI profiling. Coming to the baseline assessment results of the first assessment, the mean age in the control was 2.35, and in the intervention group it was 2.9, and the difference was not statistically significant. The baseline visual functions in the first assessment, the difference in the two groups was not statistically significant. These are the scores in the control and visual therapy group of the different domains, and the difference was not statistically significant at first assessment. At the end of second assessment, there was statistically significant difference in the functional vision score after 1 year. And among other visual function, attention span, there was statistically significant difference between the two groups. There was also statistically significant positive correlation between various domains. Coming to the discussion, OptiFlow Rehab Assist Toolkit, there is a multidimensional approach, a tailored function visual assessment protocol for various domains of CVI, target therapy catering to the visual needs by understanding the most affected domain. This study signifies the role of rehabilitative visual therapy, having significant improvement in functional vision. Eliminov et al. Used the visual attention and visual communication skill, but our study had visual motor, additional visual motor and visual processing domain. The novelty was the first study to design a neurovisual behavior assessment scale on various domains, first study to design a rehabilitative program with toolkit, and the first study to evaluate rehabilitative toolkit via a pilot RCT. Strength of the study was RCT. So to conclude, this initiative integrates technological integrated practices and a nuanced understanding of CVI, aiming to assess various domains and transform visual rehabilitation for affected children. Thank you.
Thank you. Thank you, Dr. Sweta. It was very nice. Next is Dr. Jitendra Jethani. We'll be speaking on comparison of peripheral refraction in progressive myopia and non-progressive.
A small request, please stick to the time actually, we're running short of it.
This podium or that podium?
Dr. Jitendra. Which there?
Which podium?
That
podium? There only.
In the meantime, the next presenter is Dr. Arvind Kumar. So,
मैं डलवाया अभी सुबह ही डलवाया. Delegates, we will be presenting our findings on comparing peripheral refraction. Financial disclosure, I am a advisor to SLR Private Limited. So myopia prevalence, we have enough of data now that myopia prevalence has been increasing dramatically throughout the globe, whether it is India or abroad. And the uniqueness of myopic eye, how it is different from hyperopic eye, is that it has a longer anterior-posterior length, which means that the axial length is longer than the equatorial diameter, which is not there in the hyperopic eyes. Now, how does it transform into peripheral refraction? The peripheral refraction along the horizontal meridian in the myopic eye would be more hyperopic relatively because the axial length is long. Now, it is known that peripheral retina influences the ocular growth. There is a
slides.
What is going on?
Moving.
What is wrong? Yeah. But I am not able to see the slides. मियाँ चेक करने का अब टाइम नहीं है, अब स्लाइड्स दिखाइए. यहाँ नहीं दिख रही हैं. आपने टाइमर चला रखा है.
He's not able to see slides.
कंप्यूटर में स्लाइड्स नहीं दिख रहे हैं.
यहाँ नहीं दिख रही हैं भाई.
It's seen here. It's okay.
So the myopic prevalence we talked about, what I was saying was that, you know, the uniqueness of this particular eye size, what it does is that it changes the peripheral refraction along the horizontal meridian of the myopic eye. Whereas it is now known that the peripheral refraction has been implicated in the growth of eyeball more than the central refraction. So the earlier view was that it is the central refraction which corroborates with the growth of the eyeball, and now after this wonderful article by Earl Smith, we have now known that the peripheral refraction is actually responsible for the progression of eyeball. So we did our study to measure the peripheral refraction, and how did we do that? We made a peripheral refraction aid which we implanted on the retinoscope, and this could actually measure the peripheral refraction for 20 degrees, and we measured this for most of our children. All our children were between 5 to 12 years. We included all the children who were cooperative enough for the peripheral refraction test. Children with cylindrical power of less than 0.5 diopter were only included in the study so that there is no confounding bias. Children with history of prematurity, ocular pathology, systemic ill health were excluded. We already had these patients on our roll. We had the standardized 1-year spherical equivalent so that we have the axial myopes which are to be included in the study. And the primary outcome measure was obviously to see the peripheral refraction of the eyes. And the secondary outcome measure was to calculate the difference between progressive myopes and non-progressive myopes. For the sake of comparison of this particular study, we only took right eye to avoid any confounding bias. And what we found was that the mean difference between the temporal and nasal refraction in a progressive myope was 0.7 diopter and 0.6 diopter, whereas in a non-progressive myope, so a progression, who is a progressor? A progressor is a patient whose power increases by 0.5 diopter in a year, or 0.2 millimeter axial length increases in a year. So peripheral refraction has now been known to be one of the major risk factors for increase in the growth of eyeball for childhood myopia. Multiple studies are there for myopic patients having hyperopic peripheral refraction. Our own LVP has presented their data where they found that Indian myopes had an asymmetric peripheral refraction. But the most important point is that a direct study to evaluate the peripheral refraction in myopic progressors, because we all have data, we all have treatments only for progressors, not for non-progressors. So progressive patients do have peripheral hyperopia, and our study shows that children who show myopic progression have a peripheral hyperopia of more than 0.5 diopters, both nasally and temporally. So the conclusion, the crux of the matter is the children who have myopic progression have higher degrees of peripheral myopia compared to non-progressors. The peripheral hyperopia of more than 0.5 diopter at 20 degree periphery, you can have more, you can calculate for more peripheral data also, but this could be an indicator for progression. But what we still don't know is whether the reverse is also true. More studies are needed to know if children with 0.5 diopter hyperopic refraction would progress. So how it would help? It would help if you already know that this is a patient who has come to you and you have done peripheral refraction and he has got more than 0.5 peripheral refraction, whether this particular patient will progress or not progress. So that would need more studies. So thank you so much. And these are the references.
Thank you, Dr. Jitendra. Actually, in spite of that technical issue, finished in on time. So, I mean, peripheral refraction is an important part for checking for myopia progression, and I think it's a very novel way of actually judging it. And so, thank you. Thanks a lot. I'll invite Dr.
The device works very well. He comes with all that new invention. Good.
Please help me. After this, we have the 3 award-winning papers.
Good. It's coming in. Hi.
Yeah. Yes.
All right. Can you increase the volume of the mic?
Volume is also.
Okay. So I'm going to talk about atropine in pediatric unilateral cataract patients, study on axial length and myopia progression. So the whole idea of this study came from seeking a simple solution to a complex mathematical problem. We all do unilateral cataract surgery in pediatric age groups, and we often ask, should we account for the myopia progression, should we match it to emetropia, or should we do something which is matching the other eye? So I decided to be a little more bold and use what we do in a non-pediatric cataract case to a pediatric cataract case, and I started correcting them to emetropia or the other eye refraction. So this is an 18-month follow-up of using atropine drops for presumably controlling the myopic progression or myopic shift which happens after pediatric cataract surgery. So yeah, so the problem is the same. The solution that we have right now is limited options for post-surgical myopia correction. What we generally do is we make them hyperopic and then assume what's going to happen in the future. So potential solution here is the atropine eye drop, which is seen as a good promise in myopia management for non-operated pediatric cataract eyes. So the aim was to find out if they actually work in pediatric unilateral cataract surgeries, and we decided to use either 0.1% or 0.5%, because any which way they are on bifocals. Even a higher dose is something that we are working on in the future. And we decided to measure the outcomes that come. So it was a prospective randomized control trial. Children above 6 years were taken into consideration with unilateral cataract surgery. There was group 1, which was divided into A and B. A was chosen as 0.1% atropine. They were chosen on the fact that there was either hyperopia in the other eye, or there was no family history of myopia. Then otherwise we chose a 0.05 diluted form, which was chosen in cases where either the other eye was myopic or there was a strong family history of myopia in the family. And we decided to measure the spherical equivalent, the axial length, ACD and BCV, and see what happens. So basically we corrected for near emetropia or the other eye, depending on how myopic they were. And we decided that we're going to go ahead and look for binocular vision first and getting the amblyopia out of the way, and using atropine to account for myopic progression if there's any. So we kept on checking it every 6 months. Earlier, first month, 3 months, 6 months, 12 and 18 months. And that's how we started tracking them. And we did a statistical analysis thereafter. So baseline characteristics, there were 18 unilateral cataracts which were operated, and 14 of them were the ones without the atropine. So 18 were with atropine, 14 were without. So the myopic progression that we saw, the mean myopic progression 0.25 plus minus 0.1 over 12 months, and then it became 0.35 in these atropine group, whereas the placebo group, which were on lubricants, were much higher myopic progression. Of about 0.8 plus minus 0.2 diopters. And this we saw that actually this atropine was actually working, and we came up to a better conclusion at 18 months that yes, there was a statistical difference between the control as well as the atropine group. And we also found that our choice of choosing a 0.5 or 0.1 did equally well. That could be coincidental, or it could be just experience talking, and that actually worked well even in those cases where we expected a higher myopic progression. And the comparison between both of them were good. ACD changes, there was not much fluctuation there in both the groups, and that was consistent. Axial length changes, yes, we saw more axial length progression in the placebo group as compared to the atropine treated group. And visual acuity changes, there was pretty much both of them were equal thereafter. So it's a very safe and tolerable method, and it's already been used very rampantly, so why not use it in these situations where you can actually make a larger impact. And the discussion basically, till now we were thinking atropine works with accommodation, so clearly that's not true. And clinical practice can easily accommodate atropine, which is available commercially in most cases. And even 1% atropine in the future in cases of absolute non-refractory can be used because they're already wearing bifocals. So yes, this is how it is. And that was my study. Thank you.
Thank you, Dr. Aditya. That was a novel approach for atropine in unilateral cataract. I think we're running short of time, so I will invite. So we'll invite Dr. Arvind Kumar Moria. He'll be presenting a Om Prakash Award paper on posterior phakic intraocular lens for treatment of refractive amblyopia in children.
Good morning, everyone. So this was the clinical trial on the posterior phakic intraocular lens for the treatment of refractive amblyopia in the children and adolescent. So unilateral or less commonly bilateral reduction in the best corrected visual acuity that cannot be attributed directly to the effect of any structural abnormality of the eye or the posterior visual pathway. And at least there needs to be a difference of 2 lines. This was the older definition. So does it require redefining like the alpha and the sigma female James Bond? Of course, yes, because it is the only way forward. The eye-brain ability to process the motion, the shape perception, the spatial interactions are there. We are talking about hyperacuity, the contour integration, and the binocular single vision components. So this was the first clinical trial. This is the third in the world and with the highest worldwide data. So we used a phakic IOL in the children and adolescents from the age group 10 to 19 years. Purpose was to analyze the demographics and the clinical outcomes of the posterior chamber phakic IOL for refractive amblyopia in the children and adolescents. So it was a prospective interventional study on children from January 21 to 23. Registered with ICMR inclusion criteria, ECD of more than 25,000 per millimeter square, ACD of more than 2.8 millimeter because we need to take care of the dome when we are implanting phakic IOLs. So results, age group from 10 to 17 and total 23 were there with the 14.16 plus minus 3.49 and almost equal male to female in both the groups. So this is the table depicting the mean and standard deviation of preoperative vision uncorrected to the last visit. So visual acuity improved 1.39 to 0.11 at the last visit. Again, when we talk about the uncorrected visual change from preoperative to the third visit after operation, again there was a significant p-value from 1.11 to 0.05. If we talk about the gain in the visual acuity lines, the uncorrected visual acuity and the best corrected post-op visits, so first day it improved to 11.3 lines and the last visit it was 12.1 line. When you compare the contrast sensitivity between the preoperative and the post-operative period, so it improved from 1.07 to 1.66 with a significant p-value. And we compare the post-operative endothelial cell count at the last visit, so there was only a loss of 5.78% in these group. Patient satisfaction, almost all the patients were satisfied. And we compared the stereo acuity, so it took the most large time, longer duration from more than 800 millisecond of arc to 150 millisecond of arc. So this was the last to improve. These are my references. So in conclusion, phakic IOLs can be a preferred choice for management of amblyopia in children with no incidence of corneal haze, anectasia, good refractive results with stability and good quality of vision, faster visual acuity with flat learning curve, no PI is needed in the newer designed IOL, and more multicentric clinical trials with long-term follow-up are needed for results to be more conclusive and to look for the side effects of phakic IOL like the glaucoma, like the retinal detachment, like cataract. And stereopsis, of course, took longer time to improve. Thank you so very much.
Thank you, Dr. Arvind. Actually, I mean, it's quite a novel approach, and I mean, a lot of good results are, the initial phase are coming. We have to see the long-term results of phakic IOL in children. Yeah. I think we are running short of time, so we won't have further discussion on that. Dr. Anil Gangve is there. Yeah, he will be presenting Chhattisgarh State Ophthalmological Society paper on comparison of reactivation between ranibizumab and bevacizumab in aggressive ROP.
So, good morning everyone. So this paper is basically on APROP, and again I think it's not moving there. So as we all know, APROP is a severe disease, and unless treated in time, it can result in very rapid and early vision loss and permanent vision loss. And we expect that anti-VEGFs compared to laser monotherapy are regarded as a better treatment modality, where APROP, at least in India, remains the most common indication of use of anti-VEGF in ROP. And when it comes to the agent which needs to be used, bevacizumab and ranibizumab, they remain the most commonly used agents. However, if you see anti-VEGF and ROP, there are definitely concerns, and most important of which remain reactivation of the disease, need for longer follow-up, and persistent avascular retina. But what is missing in this story is when we come to the clinical practice or real life scenario, there are no head-to-head comparison where we are telling the parents about which anti-VEGF they can actually go for their own baby in cases of APROP. So with this background, actually we designed this study to evaluate the reactivation in infants who were treated with either ranibizumab or bevacizumab. And the main objective of this study was to actually report the rate of reactivation and compare between the two groups. And secondary objectives were to report the time of reactivation and structural outcome between the two groups and identify factors which are associated with reactivation and regression with permanent avascular retina. So this was a single center retrospective case series approved by Institute Ethics Committee, and we have used commercially available ranibizumab, that is Acentrix and Avastin for this purpose. The injections were given half the dose of adult at 1.5 milliliter from the limbus, either in NICU or in ophthalmic OT. And we defined reactivation as per the ICROP3, which means there is reappearance of the acute stage retinopathy changes after initial regression following intravitreal injection. And these are the results. So during the study period, we had around 322 babies diagnosed with APROP. We excluded 214 and included 108 babies for the current study, of which 55 were treated with ranibizumab and 53 were treated with bevacizumab. If you look at the baseline characteristics of demographics and clinical feature, they were comparable between the two groups. Now coming to the rate of reactivation, if you see here, infants treated with ranibizumab had around 93% of them had a reactivation compared to around 53% which was seen with bevacizumab, and this was statistically significant. If you look at the reactivation interval, babies treated with ranibizumab tend to reactivate much earlier, around 7 to 8 weeks, while those treated with ranibizumab, they reactivated around 13 weeks after the initial injection, and this was also significant. Irrespective of the drug used, if you see, the reactivation was most commonly in the form of peripheral retinopathy, meaning the stage is appearing again and reactivation occurred in zone 2. If you look at the structural outcome, irrespective of the drug, both the groups had very good structural outcome at the final visit, but both the groups had less than 10% of the babies who actually achieved complete vascularization of retina, and persistent avascular retina was very commonly seen with Avastin, which was significant. Now coming to the factors associated with reactivation, multivariate and univariate Cox regression analysis showed that babies treated with ranibizumab had an average 3.4 times higher chances of reactivation compared to bevacizumab, and babies treated with bevacizumab had approximately 10 times higher possibility of regression with a persistent avascular retina. So these are the representative images, those treated with IVR having reactivation and treated with rescue laser, and these are with bevacizumab, again treated with bevacizumab and had a reactivation, again rescue laser is being done. So there is no study as such which has actually compared ranibizumab and bevacizumab head to head in babies with APROP. A recent study by Dr. Nimish Patel in USA, it was a multicentric study. They showed that rate of retreatment actually was much more in babies with APROP, and it was particularly higher if the babies were treated with ranibizumab. So conclude, if babies with APROP are treated with ranibizumab, they had a higher chances of reactivation, which is much earlier, and if they are treated with bevacizumab, the chances of reactivation are less, the reactivation is delayed, and they have higher chances of regression with PAR. So how do I counsel the parents now that both the drugs are equally effective in terms of structural outcome? If you go for ranibizumab, there will be reactivation which is much earlier and would need second treatment, and if you go for bevacizumab, reactivation is late, but you will need a longer follow-up because we don't know management of PAR. Thank you.
Thank you, Dr. Anil. I think that was a wonderful paper on ROP. We'll invite Dr. Karobi ma'am. She'll be presenting MOS, Maharashtra Ophthalmological Society paper. Yeah, this is a better one. It's on ROP only. Madam, it has come here.
This one?
But you need to speak little loudly. Okay. Volume is not.
Should I start?
Yeah, please.
Good morning, judges and my fellow delegates. I'm going to present this paper on is it ROP, is it ROPA? There are three cases. One is a 12-year-old female, which was preterm born at 1.4 kgs. Gestational age was 32 to 34 weeks. She showed no risk factors, but her first examination was at 6 months of age, and she was examined at a prime institute in the south. And she was taken because she had strabismus in the eye, and they found that in one eye she had a falciform fold and the other eye was doing well with a persistent avascular retina. So they decided to not do anything and just keep her on a follow-up. She saw, she's now 24 years old, and she has a TRD. She has high myopia, cataract, raised IOP, microcornea, upslanting palpable aperture, with other soft dysmorphisms like fractures of the hand and leg, high intellect, prognathism, and low set ears. She was first seen by us at 8 years of age, and the presenting symptoms are at 12 years of age. So what we saw is that at 12 years of age, she had a falciform fold in the right eye, for which nothing was suggested or done, and even we did not suggest anything. And in the left eye, she showed a fibrovascular proliferation on the temporal side, a kind of a stage 4B. And she was maintaining this. She was on 6-monthly follow-up. She was maintaining all this till she showed these kind of recurrence of activation at 12 years of age. She was a high myope with a cuneiform cataract, and she had nystagmus. And at 12 years of age, this was what we found, small vascular buds which were coming in between the vascular and the avascular retina. So we did the FFA, which showed leakages from these points. And the fundus photographs, after doing that, we followed it up with a laser to the entire area of peripheral avascular retina, and she's been following up. She's doing well. She has a cuneiform cataract, which is progressing slightly, but since she's one-eyed, she's very scared to do it, so we are waiting for her to make up her mind and come back to us for a cataract surgery whenever. She has a family history of FEVR in her cousin, where the genetic studies had revealed it. And the gene sequencing we did for her, and we found by the whole gene sequencing, she did not have any FEVR gene, and she had a low bone densitometry. The second case is an 8-year-old boy who again was referred to us late. He came to us at 8 years of age, and his first ever examination with his consulting ophthalmologist was at 5 months, and he had a stage 5 ROP in the right eye, and in the left eye, he was sent when they showed kind of buds at the junction of the vascular with the avascular retina. Same process followed where FFA was done and laser was done to these people, and this followed up with laser. Gene sequencing for this child showed a homozygous variant of LRP5. So this was a patient who had who had FEVR gene in a ROP child. The case 3 was not a preterm, was 39 weeks, uneventful perinatal period, low vision seen at 6 to 7 months. She had gone to one center, major center, and there they found that she had a stage 5 ROP in the right eye, though she was not a preterm. And in the left eye, she showed a lattice degeneration, and that was lasered over there. Her findings were short stature, microcephaly, facial dysmorphisms, and high myopia. When she was seen there at that center on 29/3/22, she had an attached retina on the left side. The right side showed a stage 5 kind of picture, and she had a laser over there. She saw us after 2 months where she complained that she couldn't, the child was kind of groping around, and this was the situation on the USG, where there was a total retinal detachment in the left eye, which we treated with a scleral buckle, and she's doing well. We decided to do the right eye also because she had an intermediate open funnel. So in that eye also she did well. And these are both the eyes. This was done for FEVR gene. And she did not show a FEVR gene, but she had a mutation in COL18A1 gene, which is consistent with a disease called as no block syndrome. So only one copy was there. It was a homozygous, it was a heterozygous presentation, not a homozygous presentation, which is required to call it a disease. So the geneticist requires to send a complete phenotype and ask the lab to perform a reanalysis. And this case teaches us every genetic report doesn't have to be taken at face value, and you have to always send the test without phenotyping, which would be hazardous. So 3 cases, gene variant found in 1, and there were studies which showed that 3.12% of patients with ROP have phenotypic resemblance, and they are called ROPER. So these are the cases that we presented because we thought they could be that, and these have to be closely monitored if you do not go ahead and do the laser treatment to the PER. Thank you so much.
Thank you, ma'am. Thank you. With this, we end the session on pediatric.